So good afternoon, ladies and gentlemen. It's a great pleasure to speak to you today, and thank you to Gira for inviting me, and thank you also to the sponsors for allowing me to be here. So what I will be tackling is the side effects of TKI therapy that many of you will be aware of, and also many of you will have experienced. So I'm happy to discuss any of your particular concerns or exchange any experiences that you may have had. So as you know, our tyrosine kinase inhibitors are targeted therapy, and the principal target is BCR-ABL. So that is what we are trying to eradicate, as you've heard from the previous talk. But of course we have what's called off-target side effects. So you don't only inhibit BCR-ABL, but you also have these additional influences on other cells, which can cause some of the side effects that we see in our patients and you have experienced. So the two ones that we simplistically blame for side effects are that of PDGF, which is shown here. So inhibition of PDGF is what we relate to the fluid side effects. So this is pleural effusion, retention of fluid, and also some of the skin rashes that patients get because of PDGF inhibition. The other one is c-KIT, and we usually blame that because of all the blood toxicity that we get. So that's a low white cell count, low hemoglobin, and low platelets that fall on treatment. So we've heard some of the side effects of all of the drugs, and these side effects on imatinib are very familiar to those who treat patients with imatinib and also to the patients themselves. So imatinib can cause skin rashes. They can be very severe. Patients who are darker because of their racial origin, as time goes on imatinib, they get progressively paler. So they have a change in skin color, and Caucasian patients find that they burn more easily. There are a number of additional skin side effects, which include changes in hair texture and also thinning of the hair. We have some more significant side effects on imatinib, and these are effects on the heart, which are fortunately rare with cardiomyopathy, so that's dilation of the heart, and also fluid retention. So many patients complain about swelling of their ankles and an increase in weight because of fluid. Imatinib is a gastric irritant, so hardly anyone can take imatinib on an empty stomach. If you do that, then patients get sick, and they have vomiting and nausea, and it also affects their bowel movement, so they often have looseness of the stool. We heard about PPIs, so this is lansoprazole and omeprazole in the previous talk. I think it's very important that we are able to use these drugs. They're very beneficial for the side effects of nausea and gastric reflux that patients get when they take imatinib. And so long as you take the lansoprazole away from your medication, it shouldn't really impact on the absorption of the drugs. And I haven't seen any data, in fact I've seen data to say that these drugs don't affect the outcome of CML patients. So I don't think we should ban patients from having proton pump inhibitors, ranitidine, lansoprazole. There has been a warning more recently about the side effects of kidney impairment on imatinib. I thought that it was probably going to be one of the more second-generation drugs that are stronger, but in fact it was on imatinib, the drug that we've had most experience with and more than a decade of experience with treatment of. Imatinib causes many patients to feel very tired, so a number of patients say that they can't cope very well with their work, that they get up, they go to work, they come back, they go to bed, and so their life repeats over and over again with this constant exhaustion, which is very difficult to manage. We also spoke about weight gain earlier in the day. I'm afraid TKIs do make patients put on weight. And it's not to do with the weight loss that you had when you were diagnosed. It's not because of fluid. Patients put weight on even after 6 months, and some patients put a dramatic amount of weight on, and this is again a type of off-target effect that is difficult to manage and not really easily tackled by actually reducing the food intake. But many patients who have had this dramatic increase in weight when they change their drug may have noticed that they lose all the weight that they had with imatinib, which is a particularly significant one for weight gain. Patients on imatinib get very dry eyes, and because of their dry eyes, they have constant watering of their eyes. So we also recommend that they see the optician, make sure they don't need any lubricants for the eyes. Patients on imatinib have puffiness around the eyes, so when they wake up, they look at themselves in the mirror and they can't recognize themselves, but as the day goes on, this gets better. It's difficult to treat with diuretics, but it's certainly a concern. Imatinib does cause abnormal liver function tests, and I know that we have spoken about this problem with the other TKIs, but we have only had significant problems at the Hammersmith with impairment of liver function on imatinib, would you believe? But that was before we were very good at monitoring the drugs, checking for the kidneys, checking for the liver function, and that's not so much of a concern at the moment. We've spoken about other characteristic side effects, that's bone pain, muscle pain, and of course cramp. Imatinib is the biggest causer of cramp of all of the TKIs, and it can be in very unusual places, so the rib, the jaw, the small digits of the hand, so it can be also very tricky to manage. Most of the time we are comfortable so long as it is a reversible side effect. And we say that these side effects are usually low grade, which means that they are not in great frequency. But you can only imagine that if you have a low amount of all of these side effects, that makes for a very miserable quality of life. Something you may have noticed, which is in imatinib's favor, is that it has a good effect on blood sugar levels. It doesn't make patients who are not diabetic feel worse, but those patients who are diabetic, you may have seen that they have less need for their diabetic medication, and sometimes they also have a very quick drop in their blood sugar levels on imatinib. It also reduces the cholesterol, so patients who came in with the diagnosis of chronic myeloid leukemia on imatinib find that they no longer need their statin, but when they stop their imatinib for whatever reason, then their blood glucose goes back up if they're diabetic, and also they find that they need their statin again and they go back to baseline. What's very interesting is that imatinib is also a treatment for pulmonary arterial hypertension, which will be looked at in the next, with the next speakers talking about cardiovascular side effects. So we have knowledge about imatinib and the experience showing the rate of complete cytogenetic and molecular responses. But of course, we are very impatient and we want to get there faster and we want to have more deep responses, and we're trying to get patients off their treatment. So a solution has been to try and hit this target with our stronger drugs, our second and third generation drugs. So the first one that was introduced in clinical practice was not nilotinib, it's in fact dasatinib, but it's been so long we have forgotten that. But dasatinib is what we call a dual BCR-ABL kinase inhibitor, and it's 300 times more strong than imatinib in the laboratory, not on the patient, in the laboratory. So all of those low-grade side effects that I told you about on imatinib, they're not there on dasatinib. You find that it's a much cleaner side effect profile for dasatinib, but it does have two big concerns. The first one is that of fluid of the lung. This seems to be an ongoing problem. I think, again, because as doctors and maybe patients, we have become so confident with the drugs that we are doing less screening, and we are warning our patients less to come to see the doctors when they have a cough or when they're breathless. And so the rate of the pleural effusions seems to be ongoing. And in our national study in the UK, which compared imatinib with dasatinib, the rate of pleural effusion was over 30%, which is quite high. It's important to remember also that you can get these side effects very late. So even if you've been fine for 3 or 4 years on TKI therapy, you can still get a side effect much later if you have tolerated the drug well. As you expect with the stronger drug dasatinib, it has a greater effect on c-KIT, and c-KIT is what I said was responsible for low blood counts, and certainly dasatinib too has a higher rate of low platelets, low white cells, and hemoglobin. So if we look more carefully at the fluid on the lung with dasatinib, this usually happens after a chest infection or a cold, and then the shortness of breath and the cough don't go away, and then you find a pleural effusion is what we call the fluid on the lung. So this is the lung field shown here. Air is black. This is the heart in the middle, and here you can see the collection of fluid, which is usually just on one side. We tried to find out at the Hammersmith which patients would get a pleural effusion. And of course, with dasatinib in all side effects, taking the drug twice a day gives you more side effects, including fluid on the lung. So that was one. It's more common in older patients, so patients who are over 60. It's more common in those patients who have heart trouble and high blood pressure. And interestingly, it's more common in those patients that have an autoimmune condition. So if you are diabetic, have rheumatoid arthritis, problems with your thyroid, those patients we found in our series were more likely to develop pleural effusion on dasatinib. If you had a skin rash on imatinib, or abnormal liver function tests on imatinib and switched for whatever reason to dasatinib, again, you are more likely to get a pleural effusion. There seems to be an immune component to getting this complication, and certainly this has been found because there is an increase in a distribution of the white cells called lymphocytes that are implicated in immune conditions, which we have found both in the blood and also in the fluid of the lung. So the way of managing the fluid on the lung is these 3 ways. Everything else is really marginal. And the earlier you intervene, the less you have to intervene. So it's critical to stop the dasatinib. One thing I find with our patients who say, I'm short of breath, and they phone for advice, is that you have to also ask your doctor, should you stop the dasatinib at the time you're ringing for advice? Because if your doctor says, come to clinic, and your clinic appointment then is not for 4 weeks, your pleural effusion on dasatinib will get greater and greater, and you will need to do much more work to get rid of it. So the sooner you stop the dasatinib with this complication, the better. And it may be better just to stop the dasatinib at the time of the complication rather to carry on to the bitter end until you see your doctor. Sometimes the fluid is problematic and we need to resolve it to get rid of it much more quickly, and then we use a short course of steroids. It's only for about 3 to 4 weeks, if not less than that, and that makes the fluid go away. Again, probably because of that immune component of the dasatinib side effect. We do use water tablets, so diuretics, but I think that's historical from the beginning. We see fluid on the lung, we give diuretics. So our chest doctors never really understood why we did that. It's one-sided, it's immune. But sometimes you also have some fluid surrounding the other organs, so in your feet, and that also may help get rid of the excess fluids. So these are the particular approaches that we have. Another unusual complication that was first described on dasatinib is a skin condition called panniculitis. So luckily this is very rare. It's extremely painful. You can't touch it. You can't have anything around the ankles where it typically tends to flare up. You can also have some lumps or bumps around the skin, and it's discolored. And this is because, again, some inflammation of the skin, which is related to immune side effect of dasatinib. And unfortunately, not many patients can continue with dasatinib if this complication happens, because re-challenging is problematic and the panniculitis tends to come back. Dasatinib, when it first got its license from the FDA, was described to cause quite a high rate of bleeding, so up to 40%. And you see, when we call things grade 3 and 4, which means that's very dramatic bleeding, and we don't tend to see that in normal clinical practice at the moment. The bleeding is usually from the gut, from the bowel, and also from the mouth. We looked to find out how dasatinib tended to cause this, and looked at the function of the platelets, and the platelets are those organelles in the blood that stop patients and normal individuals bleeding and bruising, and found that there was an effect on the platelets coming together on dasatinib treatment. So then we looked again to find out, did the other drugs cause problems with platelet function? And you can see that ponatinib is the worst in terms of effect on platelets, followed by dasatinib, interestingly also then imatinib, and then the other drugs. Dasatinib still has another mechanism that it must cause this, because it's known to cause an extra amount of bleeding. So only for dasatinib in clinical practice, if patients are having major surgery, we tend to stop the drug, dasatinib, for 7 days before the surgery, and then once the surgeon is happy and everything has healed from the aspect of bleeding, then you can restart the dasatinib. But it's important not to stay off the drug forever. So if the surgery is always being cancelled, you can't stay off the dasatinib for months and months in anticipation to have the surgery. So that's also something to bear in mind. Despite the effect on platelets, this is only found to be no worse than aspirin. And certainly aspirin doesn't cause this degree of bleeding, so there must be another mechanism that we still haven't found out about. I mentioned the problem with dasatinib and diarrhea, only to rescue patients from the hands of our gastrointestinal colleagues that tend to overdiagnose conditions such as Crohn's and ulcerative colitis that we call inflammatory bowel disease. So luckily, again, this is a very rare complication, but it can present with blood in the stool. Again, it's related to immune condition. It settles with stopping the dasatinib treatment. It's related to the dose of the drug, so the higher the dose of any TKI, the higher the chance of a complication. It also is settling quite quickly with steroids, but the most important thing is not to have a misdiagnosis for another condition, which is a side effect of therapy. So if we now look at the other second-generation drugs, so if we look at nilotinib, nilotinib in the laboratory is 30 times more strong than imatinib. Again, it doesn't cause all the very low-grade side effects that imatinib does. It's a much cleaner side effect profile, but it does cause headache, itching, and a rash. So patients on nilotinib tend to have a rash that they can't really see, but it looks like bumps under the skin, so they can feel these bumps under the skin. They can have this itching, which is very irritating, and sometimes patients take additional antihistamines such as tirozine in order to control the itching. But in general terms, it has far fewer low-grade side effects than imatinib, and the cardiovascular complications will be discussed in the talks later. An interesting aspect of nilotinib is that it does cause one of the liver function test parameters to increase, and this is the liver function test called bilirubin that makes patients yellow or jaundiced if it goes up too high. So it doesn't go up too high, luckily, but it does increase. The only problem with this is that your doctor may want to start to reduce the dose because of the increase in bilirubin, but it's not really necessary because it's not problematic. It's because of an interaction between a certain enzyme that nilotinib inhibits, which causes the bilirubin then to go up. So I mention it here because the doctors are aware about it, but not necessarily the patients, unless their dose is being adjusted. We mentioned about imatinib being beneficial for blood sugar, but what we have found from first-line nilotinib treatment is that certainly patients who are not destined to become diabetic from predictive factors tend to have an increased rate of what we call impaired glucose tolerance, so approaching diabetes on nilotinib. And certainly patients who are already diabetic have worsening blood sugar control on nilotinib, so it's something to bear in mind and certainly to tackle going forward in screening for patients, both their other parameters and also their cardiovascular risk factors. The last second-generation drug that we have is the newest one. Bosutinib is very similar to dasatinib. It's, again, a dual BCR-ABL kinase inhibitor, but it is the most selective inhibitor that we have. It doesn't inhibit c-KIT, and it doesn't inhibit PDGF. It does, of course, have its side effects, which are unique to bosutinib that you've already heard about. But the main reason why patients come off bosutinib is not, in fact, its most famous complication, which is that of diarrhea, but it's that of abnormal liver function tests. So it's very important to monitor liver function tests on all the TKIs, but particularly on bosutinib. I've mentioned it's selective and not impacting c-KIT. And that, of course, translates that it doesn't affect the blood count so much. So bosutinib is my drug of choice for patients who have very low counts on the other drugs, because I find that you have less neutropenia, low white cells being at risk of infection, and also less platelet reduction, which can be the most problematic blood complication to manage going forward with the TKIs. The other reason why I would choose bosutinib as my drug of choice is that it is the kindest in case a patient has had side effects with rashes that have been severe on any of the other TKIs, because, again, it doesn't inhibit platelet-derived growth factor receptor. This is bosutinib's side effect profile, and as you can see, all of these listed here is what we would expect with other tyrosine kinase inhibitors, but the diarrhea is a very high rate for something that we would expect on any of the TKIs. But you have now seen that the dose of the drug is related to the side effect of the drug. And although bosutinib has a high rate of diarrhea, please let's not forget that so does imatinib. But because we have become so used to talking to the patients about their response, they have been on imatinib for a long time, they tend to not mention many of the side effects that they have because they have got used to the side effect, which is not the right way to approach it. If you reduce the dose of the TKI, particularly for bosutinib, you will reduce the rate of the diarrhea. Many patients are able to tolerate lower doses without this complication, and it's not one of the reasons in the real world why patients stop bosutinib therapy. So if we look at our third generation TKI, which is ponatinib, ponatinib is very useful for targeting the T315I mutation, but I would say that having T315I is not an immediate reason to transplant. The reason why ponatinib is better with the T315I mutation is because it's given more upfront. So it's given second line rather than third or fourth line. And if you give any TKI more upfront, you will have a greater success. So the T315I mutation itself does not predict response to ponatinib therapy. It's the line of therapy. Ponatinib is our strongest drug. It inhibits everything very profoundly, including BCR-ABL. And when we were first listening to ponatinib and its side effect profile, at the American Society of Hematology meetings, we were presented with this sort of slide. As you can see, there's no mention of cardiovascular risk factors, but what's up here, or cardiovascular complications, but what's up here is rash. But the rash is, in fact, very dry skin, so it's almost as having a very dehydrated skin. The other complication was liver function test abnormalities. So if we look more closely at the skin, this is the typical appearance that our patients had on the 45 milligram dose of ponatinib. So it's a very high dose for our patients. It was extremely difficult to tolerate. 30 milligrams is much easier to tolerate. And patients had this typical crepe paper appearance of the skin. You can't see it very well here because the patient has completely smothered himself in emollients, but you can still see the typical crinkly appearance. So patients would come into our clinic and a little shower of skin would follow them. They would sit on the couch and the shower of skin would come off, and their partners would say, "I'm fed up of hoovering, there's skin everywhere." So it wasn't uncomfortable, it was just extremely irritating because it was a constant exfoliation of the skin. And when we did a biopsy, this is the typical appearance that we found. So you can see that the skin has a thickened layer underneath it here and is also lifting with a higher turnover rate. Just to finish off with ponatinib, it has an effect on vascular endothelial growth factor inhibitor, and they typically have a spectrum of abnormal thyroid function, which is low thyroid, dry skin, and cardiovascular abnormalities. I put this slide in because we're always asked about this, is whether having your TKI therapy will give a secondary malignancy at some stage. And I'm very pleased to say that we don't believe that that is the case. With very high numbers of patients that were treated both in the US and in Italy, there's no increase in secondary cancers that we have been able to find. There is some confusing data from Sweden where the conclusion shows that, in fact, it's related to the general instability of the CML rather than anything to do with the TKI treatment. So the conclusion is that it does not cause secondary cancers. So how do we manage these complications? Again, the sooner you intervene, the sooner you stop the drug, the sooner you do something about it, you're going to have less hospitalization, less visits to clinic, and less additional drugs to take. So if the blood count falls, one way is to stop the drug and allow for the blood recovery. But if you've done this a couple of times and you've also reduced the dose of the TKI in question, then you want to carry on with treatment and support the blood count with additional factors. So a very easy way is with GCSF or growth factors. So this is an injection under the skin. You take it once to twice a week. The white cell count goes up and you're able to carry on with the TKI without stopping the medication. The hemoglobin falls, but we tend not to give our patients blood transfusions. There is another growth factor called erythropoietin, which is an injection once every week to 4 weeks. And if you give the erythropoietin, you can maintain a good hemoglobin and again not stop the drug. Thing to revisit. Dose reduction is very useful for all hematological toxicity. But what about if it's non-hematological, so all the other organs that can be affected? Hematologists love steroids for side effects. You may have noticed this. It's not a high dose. It's for a short period of time. So usually a dose of 20 to 30 milligrams is used, and then the dose is reduced quite quickly, usually on a weekly to 2 weekly basis. And practically all patients are off their steroids within 6 weeks of any particular side effects. As you can see, I am a PPI, ranitidine, lansoprazole, or omeprazole fan, so I think that's very valuable. The antihistamines are very good for itching, rashes that are taken once a day, don't have any additional side effects or interaction. The looseness of the stool with bosutinib, we often give Imodium or loperamide up front. And most of the side effects you may have realized happening when you first are introduced to the drug, so when you first start the drug. And then as time goes on, there is a tolerance to the medication, if you are lucky. And then you're able to get more control on the side effects just by just riding through some of the side effects if they're, of course, not too severe. Dose reduction, again, for non-hematological toxicity. And to try and help with cardiovascular risk factors, we look at the blood sugar, we look at the cholesterol, we add statins. We choose the statin which doesn't interact with the TKI medication. And for those drugs that have cardiovascular complications, we also think about giving aspirin, which I look forward to hear about from the cardiologists. The reassuring thing is that we don't feel that there is cross-intolerance between the drugs, which means that if you have a side effect on one TKI, you are not condemned to have the same side effect on the next TKI. The first side effects will get better, but you don't know what side effect you're going to get. So that's always the problem. Until you try the drug, you don't know what's going to happen, which is frustrating for both patients and also for their doctors. But in general terms, there's minimal cross-intolerance of only about 1% between the drugs. So if we can reduce because of severe side effects, are we able to reduce generally? So we don't recommend that patients reduce their dose, which is the standard dose, to overcome BCR-ABL just because we can. We reduce the drug dose so that we get on top of the side effects. And we found that patients are still able to get their milestones, so their cytogenetic and molecular responses. And because we are monitoring more frequently, we find that those are maintained. So we never went back up on those doses. We stayed on a lower dose, but we are cautious. So we have to monitor more frequently to make sure that that dose response stays level. So this is not a standard of care. The dose reduction is there because of side effects. And if you're tolerating the drug extremely well with no complications, it's not something that we have come to the point that we will be introducing. But for side effects, it's essential for quality of life to try and balance the PCR, so the level of response, with the dose of the drug. So although none of these are licensed, We have many patients that are on 200 milligrams of imatinib. Imatinib is an unusual drug because there is a specific pump outside of the CML cell that pumps the drug in, and some patients have very good levels of this pump that is able to absorb the drug very well. Some patients don't have such a good pump outside their cell, so that's why not everyone is able to have good responses, particularly with imatinib, but there are other pumps for the other drugs. With nilotinib, on the actual SPC, so that is the licensing information, the standard dose reduction can be 300 milligrams, but we have patients who are lower. We also have patients who have lower on dasatinib and on bosutinib. With ponatinib, there is a definite recommendation from the manufacturer about how to reduce the dose. So you reduce according to the level of response. So once you achieve a chromosomal complete cytogenetic response, you reduce. There is a 10 milligram dose coming, and that will be a once-a-day dose which is being trialed on a specific study called OPTIC. But 10 milligrams once a day is almost the same as 15 milligrams alternate days. So we also have used this level of drug. But again, it's for side effects rather than standard of care. And you have to be very careful about the PCR and monitoring if you are going to undertake this approach. So when we first start a TKI, which test should we do? So hepatitis B screening, cholesterol, looking at all the cardiovascular risk factors. And patients always ask, why do I get side effects? And that's, again, because of your genetic profile. So in summary, the choice of your TKI depends on comorbidities, what you're trying to achieve, the depth of the response that you would like. You have to manage all of these additional factors, but I do beg you to remember that your doctor is a hematologist. They're not a cardiologist, an endocrinologist, gastroenterologist, and I wouldn't trust them to manage any of those conditions, only the hematology, and you have to work with other disciplines. So on that note, I'll stop and happy to take any questions probably during the break.